Good morning, everyone. Welcome to Grand Rounds. I'm so pleased to see so many of you here on the Zoom webinar. So I've just got a few announcements before we get started. I'm Jeff Miller, one of the co-directors of Grand Rounds with Kate Elkington and Christine Denny. Next week's Grand Rounds will be an in-person Grand Rounds. We hope that many of you can join us in person in the auditorium. It will be given by Daniel Pine, Distinguished Scientist at NIMH. And the title of the talk is Advancing Psychiatric Care Through Clinical Neuroscience. Again, it will be in person next week, and the talk will be followed by a luncheon outside of the auditorium around 12:20, 12:15, 12:20 for in-person attendees. And then, so just a couple notes about today's session. We really encourage questions from all of our Zoom attendees, and we will try to prioritize trainee questions. And so if you are a trainee, please consider asking a question and put the word trainee at the beginning of your question. And then the other thing, particularly for Grand Rounds that are fully remote like today's, we really would welcome you asking your question yourself. And so if you put a question in the Q&A, not in the chat, but in the Q&A, please at the beginning of your question state, "Can ask question myself." Please put that, or prefer to have my question read. If you write "Can ask question myself," we'll briefly promote you to a panelist on the Zoom so you can ask Dr. Rodriguez your question, either with camera on or camera off, according to your preference. Okay, well, it is a real deep pleasure to introduce today's speaker, Dr. Carolyn Rodriguez. I'll share her official biography with you in a moment, but she is well known to many of us at Columbia and PI. Maybe, Simon, you could share all participants if you want, so people can see Carolyn as I'm introducing her. She was with us. She's one of our own. Carolyn was at Columbia as a psychiatry resident, a postdoctoral fellow, and a faculty member in our department, who accepted a position at Stanford in 2015 and has continued to flourish, as you will hear shortly, in so many aspects of her career since then. But she was really an amazing colleague to us while she was at Columbia. And those of you who know her know what a uniquely positive and collaborative spirit she brought to her time here with us that really brought out the best in everyone around her. And so it's really no surprise to me to see how she has flourished in her career as she's moved on to Stanford. So I'll introduce her a little more formally. Dr. Rodriguez is currently Associate Dean for Academic Affairs at Stanford University School of Medicine and a consultation liaison psychiatrist at the Palo Alto Veterans Affairs. She's also the director of the Translational OCD Research Program and professor in the Department of Psychiatry and Behavioral Sciences. And in that role, Dr. Rodriguez leads studies investigating the brain basis of severe mental disorders, including OCD and related disorders. She's co-author of Hoarding Disorder, a comprehensive clinical guide, published last year by APA Publishing. She serves as deputy editor of the American Journal of Psychiatry, member of the Research Council of the APA, member of Brain and Behavior Research Foundation Scientific Council. I'm feeling exhausted already at this point, thinking of all the things that you do, Carolyn. Member of the AFSP Advisory Group and Scientific and Clinical Advisory Board member of the International OCD Foundation. She's won several national awards, including ACNP's 2022 Dolores Shockley Diversity and Inclusion Advancement Award for her longtime dedication to mentoring young scientists from underrepresented groups in the field of neuropsychopharmacology and related disciplines, and the 2019 Presidential Early Career Award for Scientists and Engineers. So it is really a deep pleasure to welcome Dr. Carolyn Rodriguez back to Columbia to speak with us today. The title of her talk is Quieting the Obsessive Mind, Novel Interventions for Adults with OCD. Welcome, Carolyn.
Thank you so much, Jeff, for that lovely introduction and for your support. And it's been just wonderful to continue to connect with you. And just want to say how grateful I am for the training and the the collegiality and partnership and sort of lifelong friendships and scientific partnerships that I've had through the years. This career really takes a village, and really grateful to be a part of the Columbia Village. And I'm excited to share with you the work that we've been doing. So I'll get my slides up here. All right. So Jeff, can you hear me? Everything look okay?
Perfect.
Oh, thanks. All right. So these are my funding and disclosures for the past 3 years. And today I'll be talking to you about obsessive compulsive disorder, or OCD, which, as you know, is treatable, and yet it takes on average 17 years for somebody who first exhibits OCD symptoms to have treatment. And that is just way too long. Part of the issue, many contributing factors, but part of it is some of the challenges of recognizing the signs and symptoms of OCD. So any chance I get, I sort of, really hone in on what OCD is. And that is characterized by obsessions, which are intrusive and repetitive thoughts, images, and urges that increase anxiety, and compulsions, which are repetitive behaviors that a person does to decrease or neutralize the anxiety. And OCD is common. It's gravely impairing. And the content, so sort of the signs and symptoms, can vary from person to person. So there's a lot of media portrayals of contamination and hand washing. But when you see it in person as a clinician, it's really shocking. So I had a patient once who washed his hands with scalding hot water, such that when they took their gloves off, you could see visible redness, marks, cracking, really, really painful. And, other intrusive thoughts are in the category that you don't typically hear of, but intrusive thoughts of fears that it will cause harm to others, even though they have no intention of doing so. Another example is an individual has an intrusive thought that they've run somebody over when they haven't, and they just have this anxiety that comes over them, and they feel the need to come back and check the drive back to the part of the road where they had that first thought and see if they had actually hurt anybody. And they'll go home and spend hours checking the news to see if they've hurt somebody. And as well, another category of thoughts that isn't as common to hear about are taboo thoughts. So these are intrusive thoughts that are inconsistent with a person's values and beliefs. And when they have these, horrific thoughts, they then do mental rituals such as prayer, phrase, repeating phrases, counting, these kinds of things to help neutralize that bad thought. And as well, it doesn't have to be a horrible thought. So some people have an intrusive thought of a name. So I had a patient once who had intrusive thought of the word David, and that caused a lot of fear and anxiety. And they had to think the word John in order to neutralize that. So not every person with OCD has just one type. They can have different kinds of thoughts. And so it's important for clinicians and trainees to keep this in mind for helping to identify people that have obsessive compulsive disorder. Like I said, OCD is treatable, and there are standard treatments, medications, serotonin reuptake inhibitors, and cognitive behavioral therapy with exposure and response prevention. These treatments help about half of our patients, and it can take a little while. So some patients, they need to try different medications or augmenting medications or augmenting with cognitive behavioral therapy. And just to direct you to a really wonderful resource, Karan et al. And Dr. Karan and Simpson then did a guideline watch. So the American Psychiatric Association has a consensus guidelines for how you treat OCD patients. And you can just Google it. It's a wonderful resource, especially for our trainees to really look and see that there's hope for treating patients with OCD. And although it can take time, the good news is that up to 7 out of 10 individuals will have reduction in their OCD treatments. Now, my research and interest really started in those individuals who aren't helped by these standard treatments. How can we help these patients who have gone through the algorithm and are still having difficulty with their symptoms? Another avenue that patients can go through is neuromodulation. So these are not both non-invasive and invasive options. So non-invasive is transcranial magnetic stimulation. There's FDA approval now. We can get these treatments. There's a deep PMS with a helmet coil pictured here on the left. And you can also do something, the FDA has compassionate use approval for deep brain stimulation for obsessive compulsive disorder. The surgery has, risks associated with it. So we think of this more, further down in the algorithm, but can be incredibly life-saving for those individuals who need help. Well, like I mentioned, my lab is really focused on how do we help patients now? How do we improve how rapidly they're relieved? Right now, it can take on the order of months for patients to get better on first-line treatments. Can we do it faster? Can we understand the underlying mechanism from the basic building blocks, receptors to circuits to neural networks, to how that generates the behaviors that we see? And is that understanding going to help us improve the precision of our treatments? So I've taken one approach that is translational. So trying to think about compulsive behaviors that we see in animal models and how those may help us understand causality in ways that we can't in patients that have compulsive behaviors, and use that knowledge in a sort of recursive way in order to be able to identify novel compounds. And today I'll share with you one example of this type of translational work. It really started with this very interesting animal model called the SAPAP3 knockout mice, which when SAPAP3 is disrupted in an animal, you see this repetitive grooming behavior. And this protein is important in the scaffolding of glutamate system. And this repetitive grooming really struck me because when you add back the SAPAP3 protein in these knockout, this repetitive grooming stops. And when it's added back in the region of a brain, the striatum, which is part of the OCD loop, that's when it stops. And so I thought, like, wow, that's a really powerful model and system. And at the same time, in the field of OCD, there are medications called glutamate modulators that impacted levels of glutamate and seemed to have clinical effects in patients with OCD. And Rupert Berman et al. And Carlos Zarada did a replication study of a glutamate, NMDA glutamate receptor antagonist, ketamine, and showed really rapid effects, antidepressant effects. And I thought it may be interesting to see if we could try a different kind of approach instead of the serotonin approach, try a glutamate approach and see if we could see some of the rapid effects and test this in obsessive compulsive disorder. And so that's the work that I did in my T30, started my T32 fellowship here at Columbia. My mentor was Blair Simpson, and really embarked on an interesting journey. So let me tell you here a little bit about how you assess for OCD symptoms. So there's the Yale-Brown Obsessive Compulsive Scale, so I'll use the term YBOX for short, and it measures obsessions and compulsions over the past week, and responder is defined as a 35% or greater reduction. And that was, the main tool at the time that we were using. And there wasn't assessments for more rapid changes in OCD at the time. And so we modified a scale developed by Ben Greenberg and al. Using an NIMH self-rated scale that would, on a Likert scale, 0 being no obsessions and 10 being constant obsessions, to see if we could capture changes in OCD symptoms at a time scale faster than 1 week. And so we were able to do the first case report of rapid anti-obsessional effects and showed the 50% decrease in this visual analog scale 1 week post-infusion. So I'll spare you the details, but it took a long time, to even sort of get this first case off the ground. We had to partner with an anesthesiologist. We got funding from Pizetsky, a very generous donor, and we're really able to test this out. I'm really grateful for that opportunity and for the training that I got here at Columbia to make that happen. In the meantime, there was an open label study that was done by Michael Block et al. At Yale. And this study looked at OCD patients who had co-occurring major depression. And interestingly, what they found in this open label study is that that ketamine worked on the depressive symptoms, but not so much the OCD. So only a 12% decrease in OCD symptoms and no responders. And the study seemed to go against what we had seen in the first case report. So to really kind of understand this and why this could be, we really dived into this and honed in on this issue of concomitant medications. So concomitant medications were allowed in the open label study, meaning that SSRIs, glutamate modulators, other medications could be on board. So to have a bit cleaner sample, we did the first randomized controlled trial in 15 patients, and we examined patients who did not have concomitant medications, didn't have severe depression, so just OCD symptoms. And what we found was replicating the first case of 50% decrease in the visual analog scale up to 1 week and 50% responders at 1 week. So I'll show you those results. So again, we did a 40 infusion of ketamine, 0.5 mg per kg infusion. Asked patients on a scale of 0 to 10, 10 being constant intrusive obsessions. And what you see is a very dramatic decrease within minutes. And patients reported things like, I'm having a vacation from my OCD. It was really incredible to see. And despite asking us their symptoms over the next 7 days, they had persistent decrease in their intrusive thoughts, long past when ketamine was metabolized outside of the body. So we don't think that there were any persistent anesthetic effects. So this was really exciting to see. But the comparison is saline, and there's always a potential for functional unblinding when you are using a saline comparison. So in order to answer some of these sort of unanswered clinical questions, we wanted to know first, is the finding replicable in patients without severe comorbid depression, without medications, and with randomization and active control? And really wanted to find out also how durable is the response. So looking at it past just 1 week. And to address this, we conducted a double-blind randomized control trial of ketamine versus midazolam in adults with OCD without severe depression. And in this study design, 45 patients with OCD were randomized in a 2-to-1 fashion to either ketamine or midazolam. We were included individuals with at least moderate severity and near constant obsessions, similar to our previous randomized control trial, not on psychotropic medications, and excluded severe depression. Patients were a majority male, non-Hispanic, with moderate to severe OCD symptoms and no to mild depressive symptoms. And they were moderately treatment refractory. So they had previous SRI trials, antipsychotic augmentation, and cognitive behavioral therapy with exposure and response prevention. So what we were able to do this time, instead of using the visual analog scale, a reviewer from our previous paper suggested, why don't you just do the Yale-Brown Obsessive Compulsive Scale, which is the gold standard, but just ask, within the past day, within the past, 3 days, and see if you can, use that scale, which fully encompasses obsessions and compulsions. And so these are results from the study using the Yale-Brown Obsessive Compulsive Scale. And what we found is that while there was a dip in midazolam, there was a significant decrease in ketamine that persisted. And, as always in science, it's really nice to see a replication. And then we actually went further to examine the white box every week for the next 4 weeks. And what we found, again, was a significant decrease in white box symptoms on average. And it was the significance persisted out to week 3, but not at week 4. And I'll show you the results here in terms of proportion of responders by group. So in red is ketamine and in blue is midazolam. So at day 1, 24 hours out, there were 55% responders. And as you can see, this persisted to week 1. So roughly still 50% responders by week 1, similar to our prior study, and week 2. And then moving then down to roughly 30% in week 3 and week 4. So side effects were, again, similar to what we had seen before. Patients with ketamine that had gotten the ketamine infusion dissociated, and those with midazolam did a little bit, but not as much. And the side effects, again, were consistent with our prior study. There was a high rate, again, of dissociation and dizziness. 5 individuals who had gotten ketamine had nausea and 1 vomited, and 8 had dry mouth. The blood pressure and heart rate changes were consistent with our previous study and also the literature of ketamine in major depression. Always like to talk about the reasons for caution, which is ketamine has side effects. And also as a clinician, you can't drive for 24 hours after getting IV ketamine. Ketamine is a drug of abuse. So we very carefully screened out individuals who had a propensity for or history of substance abuse. And it is currently not FDA approved for OCD. So in summary, our results were able to demonstrate rapid and durable OCD symptom improvement compared to the active control condition, and the effects from a single infusion on average persisted up to 3 weeks post-infusion. The wonderful thing is that in science is that's not the end of the story, but merely the beginning. There are unanswered questions in terms of the mechanism of the acute effects, the sustained effects, and why do some but not all patients benefit. So it's really important in parallel to try and ask questions about mechanism. So one of the early questions that we asked about mechanism is, yes, ketamine is a glutamate receptor antagonist, but does ketamine actually change levels of glutamate? And for several reasons, we had some suspicion as to whether that was the case or not, whether this is the route of change. And we were able to partner with Larry Kegelis and Dikoma Shungu at Columbia and Cornell, and be able to look at GLX, which is a composite of glutamate and glutamine, and look at GABA, which is an inhibitory neurotransmitter. And you can use a technique called magnetic resonance spectroscopy, which allows you to look in a particular region in the brain. So in this one, we looked at the anterior cingulate cortex, pregenual area, which is part of the OCD loop, OCD circuit, and ask questions of while patients were in our preliminary study in the scanner getting IV infusion, did this change? So again, that's in the N = 15 study. And what we found is that, surprisingly, that in this study that GLX or glutamate and glutamine didn't change, but that GABA did increase. And in parallel, we did this experiment. So Matthew Milak here at Columbia did a parallel experiment with also, partnering with Larry Kegelis. Same process, same group in depressive patients. And actually, he found that in patients with depression, GABA and GLX went up. So it was very, very interesting, and suggests that maybe there's a unique neurochemical signature in OCD relative to depression. But again, that early work has, we're analyzing the results of our larger study and seeing if we get same results and what that looks like. So, part of this larger randomized control trial, we actually also included magnetic resonance spectroscopy, fMRI, and EEG to really drill down on this. And we're really excited, just getting some data online, which I won't present now, but with in partnership with Shui and Lee Williams at Stanford, and building on really wonderful work of Rachel Marsh and Blair Simpson looking at fMRI, Simon task. We're now in a good position to be able to look at fMRI changes and see if we can look for biomarkers of ketamine's response. That would really help improve the precision. So I'm really, really excited about that piece. So stay tuned. And as we're doing this work in the clinic, also really mindful of, what does this mean in terms of the animal model? And it was really wonderful to have the opportunity to partner with Lisa Ganadin and Gwen Davis to actually go back to the SAPHAP3 knockout mice, which had first inspired me, and do a study that was essentially a clinical trial of the animal model, where you can actually quantify baseline grooming and do an injection either of ketamine or saline, and then look at grooming measurements in the same time course that we had done in the clinical study. And we, in this graph, so I just want to call your attention to the right side of the panel. So this is the wild type animals. So those are just mice getting ketamine and saline. You don't see that much changes from baseline. But then on the left, when you look at the filled in circles on the top, so those are the knockout animals getting saline. And then on the bottom, the dashed line here is those animals getting ketamine. As you can see, there's a really rapid decrease in the grooming bouts and then coming back. And so Lisa and Gwen were able to use optogenetic tools and be able to manipulate and actually look at different kinds of questions and activity. And so first, they found that ketamine increases activity of the dorsomedial prefrontal neurons projecting to the dorsomedial striatum in the knockout mice. And then if they optogenetically mimicked this increase in frontostriatal activity, it reduced the compulsive grooming behavior in knockout mice. And then conversely, inhibiting the circuit in the wild type mice increased grooming. And then ketamine blocks the exacerbation of grooming in the knockout mice caused by optogenetically inhibiting the frontostriatal activity. So taken all together, the experiments show that ketamine increased activity in the frontostriatal circuit that causally controls compulsive grooming behavior, suggesting that this circuit indeed may be important for ketamine's therapeutic effects in OCD. So on to the next mechanistic question. We wanted to try and get it. I mentioned the mechanisms of sort of the acute response, and Alan Schatzberg, every time I talk to him about this work in ketamine OCD, he's say, Carolyn, how aren't you just giving patients a speedball? What about the opioid system? And was fortunate to be able to work with him on this really interesting study on whether to ask that question, is the opioid system involved in ketamine's antidepressant effects? And so why study naltrexone? Why study ketamine? And beyond glutamate, ketamine actually acts on multiple systems, including the opioid receptor. And he had this really wonderful idea to use naltrexone, which is an opioid receptor antagonist, to see if you could actually block the opioid portion and be able to test specifically in a counterbalanced manner. And so Nolan Williams and Boris Heifetz led the study looking at naltrexone and treatment-resistant depression. And what was found is that pre-treatment with an opioid antagonist, so that's ketamine plus naltrexone here on the top, doesn't really change the depression rating scale here. But in these individuals that got ketamine plus placebo, the ketamine plus placebo, you got the antidepressant effects, and naltrexone was able to block the antidepressant effects. So what's interesting too is that it attenuates the antidepressant effects, but not the dissociative effects. So this gives us another hint that maybe the opioid system activation is critical for ketamine's antidepressant effects. And it actually opens some questions about how do we sort of reconcile this with the prior research on glutamate. One, there's been a lot of wonderful work in terms of glutamate driving transient maintenance of the antidepressant response through modulation of brain plasticity. Connor Liston and others have done really wonderful work in this area. We, are really interested in, this kind of initial, when patients first get a ketamine infusion, there's like a rapid high. So could that be sort of the opioid system driving effects? And then you have this maintenance of response. Could that be the glutamate system? And then we're still trying to understand, well, then what drives then the reversal of the effects, because ketamine's effects are transient. And also just want to give a shout out to Christine Denny, who's done so much wonderful work in ketamine in her lab, and really has been wonderful to see how she's used ketamine as a kind of a pre-treatment, and really thinking carefully about the mechanisms of ketamine's effects. Before I move on to neuromodulation, if you're interested in ketamine's effects in kids, Pablo Goldberg has done really wonderful work in this area at Columbia. So just wanted to give him a shout out as well. So, we've been talking a lot about ketamine. One of the things, again, grounded in my training here at Columbia, keeping the patient first and foremost, not one size fits all, and is, a different venue to directly stimulate the circuits involved, as opposed to having a drug that affects more widely and can have more side effects. And so we really wanted to explore non-invasive neuromodulation, and particular stimulation with theta burst stimulation. So we're lucky to partner with Nolan Williams, who I know gave a talk in Grand Rounds, Keith Sudheimer, Larry Coran, and Lee Williams. And this partnership came about because the FDA approved transcranial magnetic stimulation with the H7 coil. And this target is very deep in the brain. So I mentioned the anterior cingulate cortex, but also the medial prefrontal cortex are the targets. And what you see here listed is essentially the recipe for how the stimulation is done. So you have a certain number of pulses, certain number of sessions, certain number of duration. So as you can see, it takes, the total duration is about 6 weeks. You have to come in person. When you are doing this for OCD, you have a personalized treatment provocation. So you're actually getting the person to think about their OCD thoughts and get them online to the hypothesis behind it is to sort of activate the circuit and then stimulate the circuit. But there are promising optimizations that can be done from that. So one is to reduce the session time. The other is to reduce the treatment duration. As I'll describe ways to do that, which can actually allow for increased dose and as well see if targeted personalization of the stimulation could be helpful. And so, you've already heard about theta burst stimulation, but in brief, for those of you who haven't, it mimics the natural brain rhythms and is effective stimulation method for modulation of the cortex. And the benefits are that it can really reduce the time of treatment while keeping similar efficacy, which of course is important in terms of decreasing patient burden, having there be more minimal risks to patients. And so, this is a little schematic here of when you do the theta burst stimulation, there's different kinds. There's inhibitory, there's intermittent, there's continuous. You have a decrease in the time from 20 minutes to around 2.2 minutes. And so that allows you to fit in more treatments in a shorter period of time. And so you can, from the BrainsWay H7 protocol here, which is 6 weeks in duration, and standard treatment, which is 3 weeks, we really wanted to test something that could be done in 5 days. And the standard, the FDA approved protocol is 54,000 pulses. And with this new protocol, in addition to decreasing the time, you can increase the dose to 90,000 pulses. And so the idea behind this is just like with an SSRI, to treat for depression, you go to the standard dose. With OCD, so it takes higher doses and for longer treatment. The idea is if you don't dose somebody, you're not actually treating them. So by increasing the dose and future work doing dose finding, you can actually look and see what is the right dose of TMS to give that particular patient, as opposed to just accepting, one size fits all. So the other piece of it, Nolan and Keith created this method of personalizing the target using a hierarchical clustering algorithm to be applied to each participant's resting state scan to identify personalized functional subregions. And so how this works is that the first part is the patient comes in to the CNI, and we map the resting state connectivity. It's an 8-minute resting state sequence. And we see where on the right frontal pole subunit shows the greatest connectivity across all the ventral striatum subunits. And that one is the one that is selected as the stimulation target. And phase 2 is registration and stimulation. So you can use the local light neuronavigation system to position the coil over the individual. And so you see this like kind of T-shaped structure that kind of sits on the brain, and the local light system can see where that person is in space. And then you can enter in the coordinates and really use that to stimulate in a very precise and specific location. And so this was really just proof of concept, open label study. We did this in 7 individuals where we gave them 5 consecutive days of accelerated course of modified continuous theta burst stimulation to the right frontal pole, 10 sessions a day, so 18,000 pulses per day, and 90,000 total pulses. And here are the sort of very granular results, each person's age. And as you can see here from the Yale-Brown Obsessive Compulsive Scale, higher numbers, so closer to 40 is more impairment. And what we found is that at day 7, there was a really nice percentage change in the Y box from day 0. And so some people really had, like, here highlighted in green, over 50% decrease in their symptoms, and others in gray did not. And so that's the end of the protocol. And so the question is, how durable is it? And so we again examined every week and found that for some patients, these effects continued to persist. whereas others didn't have much effect, but then had some after, and some had some initial effects and not some after. One of the things that was really encouraging is that the side effect profile was low. So headache resolved about 1 to 3 days post-stimulation. There was fatigue that resolved 1 to 3 days post-stimulation, and there were no serious adverse events. While early, I thought I would sort of put this in, which is just kind of exploring early readouts of biomarkers of cognitive control. So again, partnering with Leanne Williams, looking at a go, no-go task, inhibitory task, we were able to show that responders showed a greater decrease in dorsolateral prefrontal cortex activation during a cognitive control task following the stimulation protocol. So again, just taking steps toward, what do we know about personalization, biomarkers that could be helpful to us with these types of treatments. So in sum, for this section, we found robust and rapid in 5 out of 7, so 71%, had at least 50% reduction sometime within the 7 to 14 days. And these results were sustained in a subset. So 3 to 5 had sustained effects up to 4 weeks. It was, some advantages are that it was non-invasive and had minimal and transient side effects. And some remaining questions to explore include, why do most but not all patients respond? Why do some have peak response at different times? And why do others have more durable response? And so just to close, we're really excited to have a platform that allows us to think about questions of causality in animal models and think about novel treatments and biomarkers of response in patients. And the next iteration and loop is really to test novel compounds and novel therapeutics. The next one is RRHNK, which is a metabolite of ketamine. And it has Carlos Zarate and NIH, Todd Gould and others have tested this compound and found that it could potentially have less of the dissociative side effects and unwanted side effects of ketamine. And so could this represent a new avenue that doesn't have the side effect profile? And currently there's a phase 2 pilot study that's going on in depression. And we are in parallel, just sort of following them in terms of getting an IND to test this in OCD and do also a similar phase 2 study looking at dose finding in parallel with the depression study to see if this could be a potential avenue. So I'm really grateful for my team. I also want to give a shout out to those of you who know Dr. Peter Van Rossel. He's doing really exciting work testing nitrous oxide in OCD and looking at insight and as well cognitive biomarkers for ketamine's treatment response. Really want to thank the team members. Some of them have gone on to medical school, tenure track positions. Is really lovely. And I also really deeply grateful for my collaborators and colleagues, which I've tried to sort of give shout outs and as I've gone along. And please contact us if you know of patients with OCD in the Bay Area. Please give us an email at ocdresearch@stanford.edu. Happy to also just help with connections or referrals or helping people. And then finally, I didn't talk about work with hoarding disorder, but really my interest in hoarding disorder started at Columbia, and we have a lot of really exciting ongoing studies and data. So happy to help on that front as well.